Good morning, afternoon, night, from wherever you're joining us. We're extremely excited to welcome you for today's session on the health stage at CogX 2020. I'm really excited to start off the day with a really interesting session on decentralizing excellence within hospital care. So does the concept of hospital actually need a radical surgery? To moderate this really interesting beginning session today, we will have Julia Hawkins from LocalGlobe.
Morning, everyone, or hello from wherever you're joining. I'm delighted to be moderating this session about the decentralization of excellence. Does the concept of hospital need radical surgery? Will the home become the predominant care setting in the future? How has COVID accelerated the adoption of digital care solutions? And what does healthcare look like? These are some of the topics that we will discuss over the next couple of hours. The first hour will be a panel discussion. There will then be a short pause, and we will then be taking an hour of questions from everyone in the audience. 5 fantastic panelists with us today. We have Claire Novorol, the co-founder and chief medical officer of ADA, the digital front door to personalized health. We have Ali Parsa, the founder and CEO of Babylon, the artificial intelligence and digital health company. We have Jacob Haddad, the co-founder and CEO of AccuRx, the communication tool for healthcare professionals starting in primary care. We have Melissa Morris, the CEO of Lantum, for workforce management for healthcare. And we have Emil, Hewage, the founder and director of BIOS, who have developed an AI that can automatically read and write neural signals as they travel from the brain to the body, and have used this to develop healthcare apps as well as to treat chronic disease. So I would just love to jump straight into questions and to help frame the session. Please, I will ask all of our panelists to introduce yourself and your companies and give us a sense of why they were created. I'd like to, if I may, start with Claire from ADA.
Yeah, thanks, Julia, and delighted to be here. So ADA is a personal health companion. It was created to enable high-quality, personalized health assessment with the goal of enabling access to better health and care at a global scale. The assessment is fully automated. It's powered by a continuously growing and improving knowledge base and reasoning capability. We now have over 10 million users around the world. More than a third of those are in low and middle income countries.
That's fantastic. Thanks so much, Claire. And can we jump to Melissa from Lantum?
Hi there, I'm Melissa Morris and I'm the CEO and founder of Lantum. Lantum is a workforce management platform for healthcare organisations. We're the largest workforce management platform by number of paying customers in the UK. We focus exclusively on healthcare. We operate in the UK and in the US. We've got more than 2,000 organisations that use Lantum across the UK. And we started because we could see that workforce management was broken. So previously I had worked as a management consultant at McKinsey, and after that I actually went to go and work at NHS London, and I could just see how broken workforce management was, and that was the sort of root cause, and the effect of broken workforce management is very high spend on recruitment agencies, so £4 billion spent on recruitment agencies every year just in the NHS. Staff satisfaction and attrition is at its all-time worst, so more nurses were leaving the profession than joining, and a lot of that is because of a lack of flexibility among the workforce. But also the processes and the software that's used at the moment is extremely old-fashioned and fit for a very different NHS to what we have today. So that's the reason why we started it.
That's fantastic. Thank you so much. And can we jump to Jacob from AccuRx?
Hi everyone. Thank you, Julia. Thank you for having me. So I'm Jacob Haddad. I'm the co-founder of AccuRx. And we are a unified communication platform for healthcare. What does that mean, and why are we doing that? So we see healthcare as a communication industry. That's what everyone is doing every day, making referrals, getting second opinions, coordinating care. And our vision is that everyone who's involved in a patient care can communicate with each other, which is very uncontroversial, but very hard to do, it turns out. We've focused so far on general practice and primary care. And we're just up to 96% of GP practices in England using us to communicate with their patients. And where we're really focusing now is growing into hospital, community, pharmacy, physiotherapy, a whole range of other services that other providers that deliver healthcare to patients, and joining the communication between them and a patient's primary care provider.
That's brilliant. Thanks, Jacob. And Emil, over to you from BIOS.
Thanks. Hi, everyone. My name is Emil. I'm the CEO of BIOS and one of the co-founders. At BIOS, we work on quite deep technology, and that is the technology to understand the signals as they travel from our brain to the rest of the organs in our body. And sort of every second, without thinking about it, our brain is constantly regulating the balance between our heart rate and our blood sugar and many other processes. And what really inspired us to start the company is a bit like genomics, where once we understood what the genome was doing for us, we could impact it and change our health. Our neural signals are the main sort of source of long-term chronic disease. And so when we saw a slowdown in the development of treatments and new drugs for things like heart disease and diabetes, we saw that getting neural data and getting it used in day-to-day healthcare, but also in drug development, could be a big way to change that. So where we are today, we started about 5 years ago in Cambridge. We now have a few offices around the world. We've built incredibly large data sets to look at neural data as it interacted with organs. And then we developed these biomarkers, so a code that we could look at to see when someone was developing a disease second by second. And for the past year and a half, we've been working with care providers to take normal remote health data, like wearable data, and then interrogating that to find a deeper view of their health. So at the moment, one of the first phases of how we're impacting chronic diseases is focusing on working with clinicians who are trying to improve their care for patients when they can't see them at the moment, and giving them an extra layer of insight. In the long run, we're actually working with biopharma and then developing our own new treatments that can surpass, pharmaceuticals on the nervous system. It's all levered on a technology to understand neural data sort of as easily as we can understand the genome.
It's incredibly interesting the breadth of companies that we have with us today. I guess I'd love to zoom out a little bit and talk about what you all see as the key in healthcare and the extent to which these have become more pronounced during and after COVID. So, for example, healthcare in the home, the access to secondary care or primary care. What have you seen, or what do you see as the key challenges currently? Maybe we can go in reverse order and stay with you, Emil.
Yeah. So for us, the biggest challenges in the healthcare system are actually from the same culprits we had before, but accentuated. So 86% of all healthcare spending has been on chronic diseases like heart failure, diabetes. And it's the most sick that require the highest touch and the most continuous care. My grandmother, for example, suffers quite extensively from a number of diseases. And now that we're going into this period with COVID and we've had to really lock down a lot of our facilities and a lot of the clinicians are held away from the patients that are most dependent on them, it's really exposing the sort of frailty of the current method of care. So for us, what we think COVID is doing is really accentuating the sort of underinvestment we've made in very large scale sort of population-wide improvements in chronic disease, and also workflows where you can provide, late stage care without having to constantly have, high touch with your clinician, because that's no longer possible and it's not going to be possible anymore. And we hear from clinicians every day sort of saying, look, I want to see these patients. I'm really worried about what will happen if I don't kind of get a better look at them in the next few months. And so that's where we're sort of seeing this demand for first a very sort of proactive and remote form of care, but ultimately better solutions than the kind of just the pharmaceuticals that leave people in this very diseased state and vulnerable to a lot of the sort of the current risks at the moment.
Yeah, brilliant. And Jacob?
I'd echo what Emil said, and so COVID has really accentuated the needs around operational efficiency, around communication, essentially around better ways of working that were there before, and they've just been heightened because whilst those previously might have just been an opportunity, healthcare is very driven by risk rather than opportunity. Not taking that opportunity has become a major risk. So if you look at how most communication happens today or previously in non-COVID times, it's the patient taking, collecting up a folder and taking notes to different appointments, or someone going around a hospital, a GP practice, knocking on doors, trying to find the person they're looking for. And people put up with that because they're used to it, and change is hard. But actually during COVID, they've had to find other ways of working. So the whole of general practice has had to be able to move to being able to consult from a laptop on your kitchen table. Patients have had to maybe be able to go into hospital without coming to the practice and picking up a letter first. And doctors wanted to look at patients' rashes without being able to say, on the phone, okay, just pop in and I'll have a look. And so we're finding that everything that's really taken off, be it patients being able to message into the practice, patients being able to respond, sending documents to patients, all these sorts of things, they're not COVID specific, but the adoptions have been massively isolated, and we're seeing that trend continue with some of the newer features around communication between organisations as well.
And Melissa.
So we have organisations that use Lantum in primary care and secondary care. I think in primary care, what we're seeing is the nature of the shifts that are being organised on Lantum have changed dramatically. So, less face-to-face, more telehealth, more home visits shielding patients. I think the one thing to note that across the board during COVID, demand is down everywhere. So I think when lockdown first happened, there was this assumption that demand was going to massively spike, and actually that didn't happen. And that's because elective procedures were cancelled, people were not comfortable going into the GP practice or into the hospital, and so what we've seen kind of on the as a consequence of that is that managers actually have, for the first time, have more time to pick up projects that are kind of important but not urgent. So, for example, we've seen, and particularly this is, in the US, we've seen this, organizations that we've been discussing about working with in our pipeline, essentially to upgrade their workforce management. They actually all got back in touch because they've actually got more time now to start to think about more important projects that could kind of help them for the next time that there's a pandemic. But I think in general, the patient demand, like we have seen across the board, there has been a massive reduction, even though of course COVID did put unprecedented pressure on the system. Overall demand is down.
That's really interesting to hear. And what are you seeing as the main challenges, Claire?
So I would add to that I think obviously so much of health decision making is in the hands of the individual. We're always self-assessing, self-triaging when there's something wrong. What do I need? Is there something I need to worry about? What do I need to do next? Do I really need to see a doctor? If yes, then what kind of doctor, and when, how urgently, and where? What's the right next step? And with the internet, with apps, I think access to information has massively increased. So people do have a lot more information to help them make those decisions, but it can be very overwhelming, and often it can be irrelevant. So, and I think. I guess in the time of COVID, Melissa was just talking about the fact that demand was massively down, but what we saw was actually people were often really delaying seeking care for really serious conditions. So pediatricians in emergency departments saying that children were being brought in very, very sick with sepsis and meningitis, much later than they normally would have been brought in. And the same across the board. At the same time, phone lines were overwhelmed with people wanting to know, might I have COVID? What do I need to do? So, it's really this sort of self-triaging, self-assessing. And I think that that's even more important now than ever with challenges accessing care and people not wanting to go and have a face-to-face appointment. So that's really what we're very focused on with ADA's health assessment. We provide at the end of an assessment navigation into the right care options for people, and we've actually seen certainly a greater demand at the end of the assessment for remote care, but also much greater demand overall for ADA's assessment. So we have integrations into health systems, for example, a health system in the US, Sutter Health, and we've seen a more than doubling in use of ADA, especially out of hours during the period of COVID, because of course people may be struggling to access, that they don't want to go and see a doctor face to face, the phone lines are overwhelmed, but people still have questions about their health. They still need to make decisions around how to access care, what's the right kind of care. So providing that digitally in a way that's very accessible, we see as really important and valuable, especially now more than ever.
I think if we stick on this theme, actually, because it falls quite neatly into the overall theme for the session, which is around does this concept of hospital need radical surgery? And maybe Claire, you want to continue and tell us a little bit about your perspective on that, and then we can go to the other panelists.
So certainly, I think that an overemphasis on centralized care and hospital care is a problem and something we need to move away from. So if somebody can be cared for, can access healthcare from their own home, remotely, or in the community in one way or another, then that should be made possible. For sure, providing, we've really seen a huge increase in adoption of remote consultations, whether that's just a voice call, whether that's messaging, whether it's a video call in the last weeks. And I think it's kind of the beginning. It's the real sort of acceleration of that, a real step change in that. But you can see that beyond even this period, it just makes sense. If you don't need to go to hospital, where you can pick up infections, and where if you're there when you don't need to be, that reduces the availability for others, then you shouldn't be there. So for sure, I think the future, we're starting to see much greater adoption in the last weeks of digital technologies and remote care, and makes complete sense to see that sort of continuing and evolving. It will, I would say, require a lot of collaboration between organizations, not only in the tech space, but the larger sort of established health systems, because it's such a complex system and it all is interlinked. So I think we've still got a way to go in terms of interoperability, data sharing, to make this really work at scale over the long term.
That's brilliant. I just want to welcome Ali. Can you hear us now?
I can hear you well. Thank you.
Great. We've gone around and introduced each of the panelists, and would love for you to introduce Babylon and tell us why it was created, and then we can jump back into the questions.
Oh, I'm so sorry. I don't want to
no, perfect.
The work you're doing. So I guess I'll be very brief. We created Babylon some 5-6 years ago now to think, can you do with the healthcare what Google did with information? Can you make it accessible, affordable, put it in the hands of every human being on Earth? And we basically try to solve the basic problems of accessibility. And that is almost easier as long as you can put most of the healthcare most people need on devices they already have. That's highly accessible. We deliver healthcare now to Rwanda. One of the highlights of our work is that His Excellency President Kagame has managed to now make primary care universally available in Rwanda, a beautiful first primary care because we managed to bring the cost down so much and the accessibility so high. The problem is there's no accessibility without affordability. And if you look at where the costs in healthcare are, they're in salaries and they are in time. Most diseases, by the time they manifest a symptom, a $10 problem has become a $100 solution. So all we do in Babylon is to try and create technologies and solutions that can deliver an end-to-end service that automates as much as possible so doctors and nurses can trade at the top of their license on one hand, and on the other hand, monitor people, take insights from their data to be able to see a problem a little bit earlier than it happens. And that allows us to deliver healthcare to quite a lot of people now, millions of people across the globe, at a cost that governments and insurers can afford. I guess I stop there.
I think just the follow-up question that I would love to is actually a question that was submitted from the audience was, do you think we will one day not deliver hospital care at all? And if so, how can we achieve this? Jacob, I know that obviously your focus is in primary care initially, but how would you think about that?
I think over the past few decades, there have been two big trends, and this isn't just in the UK, this is across healthcare systems. And at the same time, there's all this evidence that the really specialised care, the more centralised, the better. The higher volume, the better. If you're looking after strokes, if you're looking after, rare groups of cancer or providing specialist hematology services, you're way better off having trauma services, having a high volume centre, and the opposite trend. So the best care delivered, and you look at countries with far fewer resources like Cuba and how they're delivering the vast majority of care in the community, and as a result, it's far more preventive, it's far more ongoing, it's much better at handling long-term conditions. I think the shift that we'll see is the stuff in the middle, going either way. So as the technology we get is more advanced, there's a case for it becoming more centralized, because you basically need big, expensive machines or drugs or highly specialized staff there, whilst some of the work will still be remote. And where there's more routine stuff, like how do we manage someone's diabetes, how do we manage their COPD, how do we manage their hypertension, that's going to become much more, be delivered at home much more. And beyond just long-term conditions, there's really good examples of things like chemotherapy being delivered at home and services like that. So I think that, that's how I'd see the trend playing out. I certainly don't think hospitals are going anywhere in general, but they'll probably continue to become more specialized.
Ali, I'd love to hear from you, and thank you, Jacob.
Julia, I was born in Middle East, and in Middle East they say if you want God to laugh, you give him your 2-year plan, or give her your 2-year plan. And the reality is, who knows what the future is going to be, right? I was a physicist, but not a very good one. The one thing I learned is that there are so many things that interact in order to make a reality to happen, that to try and predict that is impossible. What we can predict for is the near future, and the near future, I think the hospitals are there to stay. The problem is, I used to own hospitals. I built what is today Britain's largest chain of hospitals before we took it public. The reality is half of what happens in hospitals are completely unnecessary. You take one of the most expensive real estates in the world and have meetings in it. That's fundamentally what you do, right? All the outpatient consultations, all of that. That simple half should move out of hospitals today. There is absolutely no reason for them to be. It's just cultural, right? Doctors are based in the hospitals, people visit them. And I think one thing, not a lot of good has come out of COVID, but one thing that has come out is this cultural shift of now as accepting that we could do things differently. And great people like Jacob have shown how quickly you can make those changes. So I think we will see an immediate shift of what was always unnecessary But the long tail, it's very long, and it's a pretty strong tail, and that's going to stay for a while.
That's interesting. Thank you, Emil. I'd love to hear your perspective on this.
Yeah, thanks. I definitely agree with both the analysis so far. I mean, the specialist center and the hospital itself is not going away. The thing that really interests me and what I'm seeing from our perspective is, so our vision about unlocking the nervous system and understanding it like an omic is fundamentally about control. So, why can't my grandmother know the moment her body is triggering this inflammation that's going to give her arthritis, and why can't we then allow people to step in and intervene? The interventions, as they get more complicated, will happen in these specialist centers. But as we have more digital technologies, more apps in patients' hands, more watches that people are wearing that have better technology on them, and more workflows such as the ones that some of the other companies here are developing for that connection to be remote and in the community. So once that community technology base exists, what we're seeing is that opportunity to go further in the home, on the person, very personalized. So our technology now allows people with late stage forms of cardiac disease to see when their body is reacting in an unusual way and have that control, have that visibility, and then allow their kind of more remote and community care team to be more proactive. So I think that's where the long tail that Ali described comes from, is now that the kind of pioneers of the underlying infrastructure. So everyone from sort of Apple with their Apple Watches through to even the stuff that Dake is doing with his communication platforms and such like, and many others here. As the infrastructure is laid out, the question we should be asking is, what more can we put on top of that to build that kind of proactive, more informed form of healthcare? And that, from our perspective, creates the opportunity for, much more precise biomarkers and ways of showing someone, how is your health doing, recommending on top of it. Because what you couldn't guarantee before, which you can now start to guarantee, is you can get into everyone's hand. You can be a kind of reliable underlying kind of part of their daily life. So my grandmother could reach for her own sort of view of her own health and become more of the center of care. And that's where I think you then have a stronger role and a much more kind of partnership type setup between your ongoing proactive personal care, which then ideally uses the same precision of data as the really specialist intervention centers can then queue up to deliver. So you reduce the overcrowding on the hospital side, where people think it's going to take 3 years to recover waiting list wise, but give each patient then more feeling of control and more feeling of comfort and confidence of when they need to go further through the system and up to the specialist side. And then these layers of technology and layers of precision and personalized health will stitch those two sides together. And that's sort of what we see. And that's where we've been surprised by our own sort of massive uptake on the clinical side compared to where we normally work, which is the specialist center.
That's a great segue, and I'd love for Melissa to jump in and let us know how you're thinking about this from the implications from a workforce perspective.
So I come at this question very much from the point of view of the workforce. Currently, hospitals manage their workforce in a very kind of central command and control manner. And we know that this is still in the workforce. There's actually a really good book, if anybody's interested, called Human by Dr. Mark Whitnell, which details some pretty shocking statistics on the workforce and how they're being failed by the system. And it's really, a lot of it is driven by the fact that staff want flexibility. They want to be able to work across organizational boundaries. They want to be able to work at the top of their license. They want to have a say in when and where they work. And that's one of the core drivers actually to the reason why clinicians are leaving the profession. So I mentioned earlier, more clinicians last year left the profession than joined, and this is not a one-off. This is a trend, and I think a lot of it is also because. So it's because of the way that hospitals have always worked. They roster staff into shifts. Rostering is quite a complex task, and so actually starting to try and take into account clinicians' preferences just makes it way too complex for the technology stack that many hospitals run off. Many hospitals do it off pen and paper, and also they're not really connected to each other. So you'll have hospitals that will manage their workforce in isolation to neighbouring hospitals. And actually, when because we are massively under-doctored and under-nursed, we now need to really think about how we can actually share staff across organisational boundaries. And that's going to require a massive overhaul in the technology that exists within hospitals today, because those systems that they use they're just not connected. They're not optimized to take into account staff preferences, for example. It's very difficult for somebody to work in one organisation and then go and work in another one because of all the compliance checks, and also just really because the technology stack is just not in place. And so this is really what Lantum is set up to do, is to really help the workforce kind of decentralize themselves and actually start to look at where they want to work and start to work across organizational boundaries in this manner and work much more flexibly. But I think, the question of does it need radical surgery? Yeah, it really does need radical surgery, and I think there's two parts to it. One is the technology that's in place at the moment just needs completely ripping out and put it with new technology put in place. And the second piece is around the culture. So there is a culture within hospitals around not giving the workforce a say, to when and where they work, when and where they're rostered, and that culture really needs to dramatically change if we're going to kind of work into the future, where obviously more care is going away from the hospital, but also where we really need to make the workforce more fungible across organisations to tackle this issue that we have of being hugely short-staffed.
Thank you so much, and I'd love to actually speak to Claire and hear how do you think about the tools that we now need in order to, I guess, accelerate this decentralization of healthcare? What do you see as the areas that we need to develop and focus on as an industry in the near term?
Yeah, so I think echoing some of the things that have been mentioned in the last minutes, really putting more power in the hands of the individual. So enabling people through a combination of remote access to health professionals when necessary, but also self-assessment and access to personalized, high quality, reliable, trustworthy information about their health, being able to take as much control of their health and manage their health proactively from home wherever possible, access care easily, conveniently, and again, remotely when necessary, when that makes sense, but also being able to make better decisions about when it is necessary to seek in-person care. So really a combination, I guess, of access to the information, but also then an ability to navigate to the right care when care is necessary.
That's brilliant, and I'd love to jump to you, Jacob, because I know that over the last couple of weeks and months, you've obviously launched a number of different products as a result of COVID, and I guess I'd love for you to describe a little bit more about that in terms of what it was that you saw. And what have you seen as being the products that have been, most effective? A lot of people are talking about video consultations, but I don't know, is that really the one that you're actually seeing can be most game changing? And would love your perspective.
Of course. So I think it was the 2nd of March, we asked our users, we've got quite an active user Facebook group, how can we be helping with COVID? What about, we've got these structured questionnaires that we send to patients for managing things like asthma and COPD, providing that for triaging whether patients have symptoms of COVID. And no one was really interested. A week later, COVID was spreading. It's still, we were, I think maybe single digits in the UK or double digits in terms of infected case, confirmed cases. And we spoke to practices who were saying, we're having to call up every patient now and check if they've been to Northern Italy, if they've been to Wuhan province, if they've been to Iran. Those were, where the public health advice was saying people would be at the most risk of infection from. And also, we're quite worried about some of these patients coming in. Can we do things remotely? So we took a bit of a punt on that Friday. I remember it, the 9th of March. I remember saying to the team in the afternoon, is this, something we should be doing more of, responding to COVID, or actually is this just a big distraction? It hadn't got, at that point, it was still very much something happening outside the UK. It hadn't really taken off yet. Doubled down over the weekend, and I don't like to claim it was a sort of, yes, we could build something over the weekend, but only because of years of building infrastructure and integrations and getting adoption. So we worked over the weekend to build a way for practices to screen patients before an appointment. Really simple. Send them an SMS with a link. The patient clicks the link, answers their symptoms and travel history, and to do video consultations. And there are a bunch of video consultation products for NHS practices. So we are software. We are not a provider of healthcare like Babylon is. There are a bunch of solutions, but really we saw not only was there a need for something where a patient didn't need an app and didn't need to create an account, but most GP practices didn't even have webcams or headsets. So we had to really build something that worked, that they could use on their own devices, that integrated with their system. Got that out, tested it Monday morning. Tests went all right. Tests went well. Monday afternoon, 10 on for 3,500 practices that were using us. And then, a few things happened. So we saw that take off very quickly, adoption take off very quickly. So we went from 50 new GP practices signing up to use it a week to 1,200 a week for a few weeks. Our pause support team were completely, their ticket load went up 10x. And then we got video out. We obviously had to, that was V1. We had to keep improving it and improving call completion rates and handling all the people on older smartphone versions and making the user experience more user friendly for people who are less used to joining, who might never have joined a video call or video conference in their life, which is something that I imagine most people on this section are much more familiar with. But what happened then was we had this opportunity of all these other features that we'd been wanting to do. We suddenly had this burning platform getting them out. So practices being able to send documents to patients instead of having to come in and pick them up. Practices want patients coming in to pick things up. Practices being able to get responses from patients. A year ago, practices said, please don't let patients respond. If they want to respond, they can phone up. And if they can't get through, they can phone up tomorrow. Completely changed because practices were like, well, actually, we can save all these phone calls. Practices being able to send them photos. So video is good for some things. It's good for getting a sense of, how animated a 2-year-old is, if the parent's worried about them, or for new patient reassurance of seeing their doctor. But it's not good for looking at rashes. It's not good for dermatological problems. A photo is significantly better at that. So we got that out. We had practices quite concerned about how they're going to monitor patients in the community. So patients who weren't sick enough to warrant going to hospital, but there was concerns around rapid deterioration, which was quite a common feature of COVID, particularly after 5 to 7 days of symptoms starting. So we built a way for them to monitor patients remotely, again, without the patient needing an app or an account or anything like that, based on SMS and web. So those were some of the products we built over the first sort of 6 weeks that we were responding from March and through April. And the team was pretty flat out then. And we've then moved more into trying to get back to our sustainable delivery mode. So communication between providers has been a focus of ours for a while, and has come up as more of a need during COVID. And so we're moving that forward. And also, I shouldn't forget, it was an opportunity for us to start getting quite serious adoption in hospitals and community providers. So previously we'd just been in general practice. Similar needs in hospitals for example, video consultations for outpatient appointments, family visits, end-of-life discussions with families, things like that. So we took our GP package product, which is desktop software that you install on your computer. For people who remember running installers on Windows back in the day, that's what we've got to do to work on NHS IT. So I've packaged up a web product and got that out. But to your point around video, I do think, and not just our users say as well, video gets a lot of attention. It's very it's very easy to understand. It's easy to put a stock image in a news article about digitizing healthcare with a patient seeing their doctor remotely. It doesn't in itself drive a huge productivity gain for the health system. You can do clever things like, we're talking about, let's talk about workforce. You can do really great things around pooling your supply and things like that. Obviously, for patients, it's quite a lot more convenient. But what providers have found far more beneficial is being able to get messages back from patients, being able to send documents, like really, really basic stuff that, the health secretary isn't going to go and stand on the stage and say, we need to have a way to send documents electronically to patients, because that should have been there a while ago. But that's where we've seen probably the most impact. So we're doing sort of 30,000-ish video consultations a day, but around 230,000 patient messages a day, over 40,000 documents a day, things like that. So video is a tool in a toolbox of communication kit for healthcare providers.
Thanks so much, Jacob. And I'd love to hear from Ali your perspective on this one, in terms of obviously the impact that you've seen of COVID and how you've responded, but also when we look ahead at this decentralization of excellence, what are the tools that you think we need to adopt and develop to enable and accelerate that?
Look, we are a provider of healthcare. We are an accidental technology provider, because some of what we needed in order to provide healthcare wasn't there, so we had to build the technology. Frankly, if great organizations like Haddad and AccuRx, RX, and all those existed when we wanted to do it, we would have just licensed the technology and would have moved on, right? As we will hopefully one day with BIOS technology when it's ready. So when you look at this from the perspective of a provider of healthcare, what you look at is that actually what's the right system of delivery of care. And I think the problem we have in healthcare is that the system of delivery is wrong. Fundamentally wrong. Pre-COVID, post-COVID doesn't make a difference. It's just wrong. Because we don't deal with healthcare. We wait until somebody gets sick, and then we deal with the crisis and emergencies. This is equivalent if you're running your car until the engine blows up, and then dealing with the engine after it blows up, right? We don't do that in any other aspect of our life, and yet we seem to do that very comfortably in healthcare. And that is our challenge. Fundamentally, that is our challenge, right? So what we do in Babylon is try to say, can we reverse the pyramid? Instead of trying to deal with crises and emergencies, can we spend a lot of time upfront looking after our people so well that hopefully they get into emergencies and crises a lot less? Now, when you look at it that way, and we saw that with COVID, was that people actually immediately, the first thing they need is information. They don't need to talk to doctors. So I give you an example. When we launched in New York together with Mount Sinai, we did so because what Mount Sinai was saying was a deluge of people coming into their hospitals and packing up the emergency rooms and making the hospital almost dysfunctional. And I agree with the previous speaker, I think it was Jacob, who said the problem is not video, because frankly, a doctor behind a mobile phone is as rare and as expensive as a doctor in a hospital, right? It doesn't really make a difference. The problem is, how do you avoid sending people to their doctors and dealing with their needs? So we created this funnel of technology first, and it could have been something as simple as videos. I'll give you an example. When we were seeing people asking us, how do we wash our hands? So we created a video on here is how you clinically wash your hand. And it was getting 100,000 views a day, and today it's got over 2 million views, for instance, right? And that was before other people started putting videos on. And then if you had a symptom, we basically put a decision tree on it. People talk about AI. Frankly, this is just a simple decision tree when it comes to COVID, because there wasn't enough data to build any AI deep knowledge base on it. And then when we told them that, look, you need to self-isolate, we then put them a monitoring capability for them to do so. We could deliver all of that per patient for 50 cents, right? I mean, it was so cheap and so easy to deliver. And today we have contracts for 8% of the UK population to look after them, right? We do the same in New York for a lot of people too, and in California for 2 million people, and so on and so forth. Then the next one comes, which is somebody needs to talk to somebody. But why do they have to talk to a doctor? So we set up this live chat where they were talking to clinically supervised but non-clinical workers. And then eventually, if they needed to talk to a doctor because the monitoring said so and the chat said so, we connected them to a doctor on a video or a audio. And then in a very rare cases, we send them to hospitals. By putting that funnel in place, we managed to completely invert the pyramid and look after people a lot more quickly. And what was fascinating to me is in this period, how all these telemedicine companies boasted about how many more consultations they were doing. But what that tells you is an unscalable model of business, because it basically means more demand means more supply, as opposed to an scalable model of business, which means more demand does not change your supply base. Like, you can leverage your existing supply base. And what we saw was you could now look at the 4 times as many people with basically the same workforce. Our technology was working harder, but our people were working the same. Now, that worked really well for COVID. It is now, but COVID was not the only health crisis we had. We have crises of chronic conditions, for instance, diabetes, far more importantly, mental health, all the time. We lose 1 million people a year, folks, 1 million people a year to suicide. And we do nothing about it. We just quietly sit down and let it happen, right? So imagine a world in which we can give people everything we gave them for COVID, and we can give it to somebody with mental health issues. We can give it to somebody with diabetic issues, with COPD. We try to avoid this crisis. And that is what we've done and what we're doing. But look, all of us on this call and all the people who ever took part in CogX as a technology provider or technology or digital health provider, they were a tiny fraction of the healthcare system. But what we can do is we can be the pioneers that show the rest of the healthcare system how it could be done, and then hope that they can pick it up, because they're really the ones who serve the billions. We'll be lucky to serve the millions. But if we can be the experimental ground in which people can say, wow, it can be done, then I think we've done it.
That's excellent. Thank you very much. I think we're now coming to the end of the panel session. I think Eleanor is coming back in, and we will then go to some Q&A from the audience. We've got lots of really great questions coming through, actually.
Well, it's an interesting question, and thank you, Julia, so much for moderating, and to our fabulous panelists for sharing their views with us. I think you kind of really helped set out a clear vision of how healthcare can and should be delivered at home and within the community. And I think the particularly interesting thing for me was how ultimately the current context in COVID has really, I guess, kind of highlighted what the realm of the possible actually is, and the importance of the digital health agenda, even more so than usual. So for our attendees, depending on the pass that you will have, you'll be able to follow the speakers into a Q&A session to continue the conversation with them. And then in terms of what happens next in the health stage, so our next session will be at 12, and it will look at prevention and what the last 6 months have taught us. So do join us again for that session if you don't have the Q&A pass, and if you are interested, do follow the conversation with the speakers.
Want access to more CogX videos? Subscribe now for free at cogx.co.